I will begin the recording.
This meeting is being recorded.
And the floor is yours.
Good afternoon, everyone. We're going to start the meeting today with the meeting of the Audiology Practice Committee. So I'd like to call the roll for hopefully those attendees. We do need 3 for a quorum. So can I ask Karen Chang is here?
Here.
Amy White?
Here.
Dr. Valdez, I presume, is not here by what Mr. Sanchez just said, but I'm here, so I believe we do have a quorum to carry on the business of this committee. I would like to open up for public comment not on the agenda at this time.
This is the moderator. Our Q&A panel is open. If you'd like to make a comment on items not on today's committee agenda, you can do that by locating the Q&A box, which you can do by accessing the question mark inside of a square icon. Should be located in the lower right corner of your screen. Click on that, you'll see a text box. You can simply type comment into that text box and submit that to our panelists. If you are calling into today's meeting, you can also raise your hand by dialing *3, and I can call on you from that way. If you do make a request to make a comment today, when I tell you it is your turn to comment, I will let you know that I have sent you a request to open your microphone. To do that, you'll see a box appear at your end that says unmute me in a blue button. If you click that blue button, it will unmute your microphone. And each commenter today will have a time limit of 3 minutes, and I will be providing a 30-second reminder when your time is about to expire. Seeing no requests for comment, I will close the Q&A.
Okay, thank you. I'd like to move to agenda item 3 for the Audiology Practice Committee. I believe Maria Lorenzo is going to explain the issue to us.
Thank you, Dr. Raggio. Attaches the draft of the meeting minutes from September 23rd, 2020 Audiology Practice teleconference meeting. We are presenting it so that we could publish to the public, as well as have it as an underlying document for the regulatory process. This meeting minutes contain discussion from earlier discussions regarding the clinical and RPE requirements. It also includes discussions regarding changes to the praxis exam, Medicare, Medi-Cal, or Medicare, Medicaid merit-based incentive program, as well as waivers in response to COVID-19. If anyone has any corrections or additional information that needs to be added, let us know. Otherwise, the committee can motion to approve the minutes.
Could you tell us a little bit about why we're seeing these minutes from 2020 at this point?
They're backlogged items, tasks that weren't completed because we had, there was a staff that was on, I believe, leave. And so we were just limited staffing, so we weren't able to complete it. And it was a recording meeting. So it did require some time to sit down and process writing the information. And so, yeah, but yeah, we had just had limited staffing at that time. And so now that I'm here, I'm completing just backlog stuff, so.
Okay,
Maria's so nice, but I also forgot. So because this one was a standalone meeting, it was my oversight when we have the next audiology committee to do the minutes for that.
Well, better late than never. I'd like to ask the other committee members if they have any corrections, comments about the minutes. Not hearing any. I'd like to ask for a motion that we accept the minutes from September 23rd, 2020 of the Audiology Practice Committee meeting.
I'll make a motion to accept those minutes.
I'll second.
Okay, thank you. Can we open for public comment?
This is the moderator. I've again opened that Q&A panel. If you'd like to comment, please access that Q&A text box and type the word comment and submit. If you're a call-in user, you can dial *3 to raise your hand. Seeing no requests, I will close the Q&A panel.
Thank you. If there's no further discussion, I was going to ask Sharice if she wouldn't mind calling the vote.
Absolutely, not a problem. Dr. Raggio?
Aye.
Ms. Chang?
Aye.
Dr. White?
Aye.
Motion carries.
Thank you. Okay, I'd like to draw your attention to item number 4 on the agenda for our committee. It says discussion and possible action regarding statutory and/or regulatory requirements related to audiology aid, scope of practice and supervision requirements as stated in BPC section 2530.2 and Title 16 CCR section 1399.154 through 1399.154.7. I would like to provide some background, although our board binder of notes are very good at doing that. But I remember living through this for many years, and I'd like to tell you a little bit about the background of why this is such a thorny problem. And that is that the issues surrounding the utilization of audiology aids by licensed audiologists has been debated for well over a decade, probably much longer than that. So obviously, a clear resolution to the issue has been elusive. That's because there's a controversy surrounding the tasks that an audiology aid can be allowed to perform. There are audiologists who would like to train an individual to perform most tasks that an audiologist would perform, mostly basic elements of their practices, such that the aids can do these tasks in a way that frees the audiologist to perform the more complex tasks that require clinical judgment based on education and experience. Other audiologists and the board feared that an audiology aid who lacks classic clinical training and education could potentially cause consumer harm. Therefore, at this point, and all along, I should say, audiologists are seeking guidance from the licensing board to determine which tasks are acceptable and which aren't. Now, Title 16 of the California Code of Regulations states and defines an audiology aid as one who assists or facilitates while an audiologist is evaluating the hearing of individuals and/or is treating individuals with hearing disorders. Now, that definition is fairly broad and ill-defined and doesn't discuss levels of supervision either. So the notion, however, is that the licensee would train an aid extensively and would not allow an aid to perform tasks that would otherwise cause consumer harm. Now, some of the tasks that an aid might perform would involve what are termed invasive procedures. That is otoscopy, ear impressions, or tympanometry, for example. While other tasks are much more simple, and that something like ordering supplies, making chart notes, making appointments, cleaning and ordering hearing aids, and many other small tasks like that. Now, many audiologists would like the tasks that aids can do to run the gamut of the more invasive to the ordinary. And their rationale is that if an aid is not allowed to do those things, even after extensive training, or if they would require over-the-shoulder supervision, what's the point of having an aid at all? And while the board understands this point of view, we are a little more circumspect and have been over the last many years about determining what are acceptable tasks. The notion being that without proper education and training, the potential is there for significant consumer harm. Others feel that the responsibility for consumer harm lies with the licensee. So in order to approach a resolution to this problem, the board is essentially looking at 3 different avenues for possible resolution. One is that we could leave things the way they are, which is working, but doesn't appear to be a very satisfactory option for licensees. Secondly, we could modify the existing regulations to include more clarity on the tasks that an aide can perform with stipulated levels of supervision. Or thirdly, develop a new license type of an audiology assistant with regulations similar to those of speech language pathology assistants that would require a particular level of education and continuing education in order for the board to gain confidence in allowing these individuals to perform more invasive tasks with less supervision. So I'd like to draw your attention to page 2 of this section that looks at the issues that this committee needs to look at. Should we revise our CCR 1399-154 to better reflect the role and responsibilities of an aide in an audiology practice? Should the definition of audiology be expanded to define the role of an audiology aide within the practice? Should the definition clearly delineate what is outside the scope of tasks of an audiology aide? Should the board create a regulatory section regarding activities, duties, and functions outside the scope of responsibilities, similar to that of SLPAs? Should the board revise the regulatory sections regarding supervision of an audiology aide to define levels of supervision for particular tasks? Should the board revise the regulatory sections regarding revision of the audiology aide to define the types of tasks and activities they can perform? Now, you might recall, though, the Sunset Review did give us one piece of regulatory change that we can utilize, and that is that we now can create a biennial renewal requirement for audiology aides, because as you know, at this point, they are registered once, and we never know whether they've continued to do that task. They never have to register again. They don't have to check in. They don't have to do CEUs or anything like that. So those are the issues, lots of issues related to regulatory change, but we should also consider option number 3, having to do with creating a new license type. So having said all that, I'd like to open the discussion to the rest of the committee.
So thank you for summarizing, Dr. Raggio. I know some of the questions that have come up over time have been, related to how the SLPA classification was really developed within speech language pathology and where that line of demarcation was, where that determination was made that they couldn't just, continue to have aides, that they needed to have this more formal program in addition to. And if audiology is looking like it needs to go on the same route. But as we don't have any speech language pathologists on our practice group here, I don't know if I can really ask those questions right now, save those for the board meeting at large.
Oh, I see what you mean. Yes, we do. It would be nice to have their input here, but we will bring this back when we report it to the board under the chair's report, and we'll be able to solicit information there.
Okay.
Knowing of these 3 potential options, perhaps there's more, but those are the 3 that I see. Is there an avenue that you or Ms. Chang would like to see the board undertake?
I think after reviewing the options and talking at length about looking at the Sunrise policy and what it would take to, justify making this a new category of licensee, and looking at how it's currently written, in the BMP code about the use of these aids, it seems, in my opinion, it seems like we might do better just creating some sort of better defined parameters or bumpers for the current use of aids. Again, maybe looking to the AAA statement on ethics and the AAA statement on the use of aids about not being able to make, diagnostic decisions and et cetera, might be enough to strengthen the parameters that we might feel more comfortable with leaving it fairly wide open for the audiologists to create their own plans. I think, should those plans include which tasks the aide are going to be performing, how they're going to be trained to do those tasks, how they're what the method of assessing them in their competence in those tasks will be, and then what the ongoing or maintenance of assessment would look like. Might be things that we might ask to include in such a plan. But it seems really clear, at least from national guidance as well, that the purpose of these aids is really to function under the discretion of that audiologist and how they've trained them and what needs they have in their clinical practices. And I'm real hesitant to place limits, significant limits on that, as it is part of the professional license to take on that responsibility to have an aid.
Let me refer to what Dr. White is talking about in terms of the sunrise requirements. Apparently, when you want to have a new license type, it is an arduous task to convince the legislature that there's a need for this license. Apparently, there are lots of entities, professional entities and otherwise, who would like to say that they're licensed, and that puts a burden on the legislature to have to pick out what's a legitimate reason and what isn't. So that means that you have to respond to a number of different elements, providing data, in fact, that this license type is necessary, why it's necessary, what are your rationales, what are the plans for doing this. Is quite a detailed endeavor. On the other hand, I wouldn't want the arduous nature of that to close the door on that if it would ultimately give the board more comfort and clarity on what an audiology aid can do if we're going to model it after the SLIPA model. The SLIPA model says, to my understanding, that SLIPAs have to have a certain amount of education. They are licensed and they have to complete continuing education. And all of those factors together is what led to allow them to have the breadth of practice that they can. And wouldn't there be an advantage to having audiology assistants follow a similar pattern of education and I guess provide assurances through those mechanisms that we can trust the consumer harm is not imminent, as sometimes we fear now when they're untrained beyond the audiologist.
Dr. Rajo, can I just chime in real quickly?
Of course.
This is Paul. I think that the audiology assistant discussion is something that the board is going to talk about, and I do understand how closely related that is to the discussion that we're having right now. But I do want to point out that I know that we all know that consumer protection is what's guiding this, and not how difficult it would be to go through the sunrise process. But I do want to point out that even the regulatory process for making changes to the audiology aid scope can be equally difficult and arduous. So I think that we really need to, at some point, regardless, we're going to have to touch this audiology aid scope and what they're going to do. So I just wanted to point out that there is some equal complexity on both sides. I don't think that one is more than the other.
Well, that's really interesting to know and appreciate that that's the case, because I guess inherently I thought that the sunrise was much more difficult. But of course, you guys know very much more than we do about the regulatory process.
We tend to shoulder, this is Charisse, we just tend to shoulder that internally and not talk too much about it. So yeah, either way, a pretty big, heavy lift of workload. So, but probably, at least for the aids, the one we're discussing now, something we have to tackle either way.
Right.
So.
Can I is there and again, this would just, I don't know how much board staff can fill me in here, but I have a little bit of confusion around kind of the genesis of this aid quandary, in the sense of, 15 years ago, I believe I put in, a request for an aid, and I submitted my training plan, and, I had approval for that aid to do any number of tasks, provided I think I'd written it as supervision within the building. I'm in the building with the aid. And they could do otoscopy and they could do ear impressions, et cetera. And it really wasn't an issue. Whereas it sounds like at some point a change was made where it was decided that certain tasks that used to be approved are no longer approved because they're now considered invasive, even though there wasn't necessarily a change. Was there a change, I guess is my question, in how the board decided to approach these plans? Like, was there a change in the decision-making process there that, that I've missed?
I can't speak to a change per se, but what I can say is that when we look at these applications, we're looking at them under the scope of the current laws and regulations related to an audiology aid. And frankly, there isn't much there. When I did come to the board, we were looking at creating a list of what they could do. We were looking at creating a list of what they could not do. And I think that the board kind of looked at both sides. At a certain point, there was some other complications with statutory language that prevented the board from moving forward based on legal advice at that time. So I don't know that there's been a change, but I do think that we're looking at it closely under the scope of the current statutes and regulations. And aside from the topic of a potential assistant designation, we do have to kind of, as a board, decide what can an aide actually do and what does the law permit them to do? And I think that's what our task is here. And obviously looking at it through the scope of consumer protection. I hope I answered your question, Dr. White.
Sort of. In terms of what does the law permit them to do, can you maybe point me to that definition a little better? I guess because all I've been reading so far has been related to the submission of a plan, that all the tasks will be in the plan, et cetera, but there's not any sort of specific limitation written that I could find.
Well, the definition says an audiology aid assists or facilitates while an audiologist is evaluating the hearing or treating individuals with hearing disorders. That suggests to me that the definition says you have to stand there with a scalpel all ready to hand it. It's that kind of thing. It's while the activity is going on, you're there to assist, as opposed to I'm going to train you to do an ear impression. And you, once I feel you're competent, I'm going to let you go off and do that. It doesn't really encapsulate that. And you can see the problem with that it doesn't. But I do remember 15 years ago that the board looked at this and said, it looks as though, if I read this right, that an aide could do just about anything an audiologist could do, so long as they were supervised. But the level of supervision was never stipulated. So it made the board nervous that these untrained or clinically uneducated, I should say, individuals were allowed to be doing anything an audiologist can do. And that was a hair on fire moment back then. But again, trying to come up with these lists of do's and don'ts, as you and I, Dr. White, talked about, it's really hard to do because the profession is often changing, clinical tasks are changing, and it's hard to capture everything that might come down the pike. Although we could work on language like that, it's hard to do and not leave something out or include something we shouldn't.
Agreed. And it seems like if you were to compare the audiology aid, to, for example, a dispensing trainee, that the requirement for training is already more apparent on top for the audiology aid, to have a formal plan that's submitted to the board, whereas a trainee isn't. And there's no restriction on what the trainee can do in terms of invasive procedures like impressions on patients. And in fact, the trainee only has to have a 20% supervision in there. So I'm trying to understand, I guess, why it seems like it's been so strict for the audiology aid versus a dispensing trainee right out of the gate, and why they're those restrictions just seem so different is all.
And you know, to kind of piggyback on that, on those comments, Dr. White, I do think that a lot of the issues that we're dealing with are kind of the evolution of the board. The hearing aid dispensers came to the board not very long ago, and they came with hearing aid dispensing trainee requirements that the board recognized needed to be updated. And that's what we're looking at right now, the level of supervision and what a trainee can do. I think the hearing aid dispensing committee is looking at that. I do want to point out that the limitations of a trainee are still under the parameters of what a hearing aid dispenser can do. And a hearing aid dispenser is testing and fitting for the purpose of selling a hearing aid, whereas an audiology scope is much more broad than that.
And I think we should also clarify that when we're talking about an aid as a registration, that's an ongoing permanent registration, it's different than a hearing aid trainee whose sole purpose is to accrue the experience and training necessary to pass the examinations to become an independent hearing aid dispenser. So it's hearing aid dispenser trainee, while it's very different than an RPE, it's the same kind of training license category where it's accrue the experience in order to pass the exams and meet the requirements for licensure, as where an aid is never intended to do that. The aid is not a training category where they're going to learn and then they're somehow going to get licensed as an audiologist or anything else. They're just supposed to stay in that category. So
I do fully understand that. I guess just going back again to the when Marcia was talking about the board at the time getting a little concerned about the risk to the consumer, the risk to the public about invasiveness of what's happening on the aid, that invasiveness is no different than a trainee that is not required to have that supervision plan and can be functioning unsupervised 80% of the time. So I was just trying to rectify that.
I think Todd will, or Mr. Borges will help us lead the charge on that during the hearing aid dispensing.
Hi, this is Karen. I just have a question maybe to ask Marcia or Amy. Would it be, I'm looking at the question, should the board create a regular section similar to the SLIPA? Can we do that? So that way it's kind of similar across the board for both SLIPA and hearing aid dispenser aids?
Yeah, I don't know about that, about the hearing aid dispenser aid, but that is a good question in terms of could we make some equivalency between an audiology aid and a SLIPA? But before we kind of attack that, I'd like to ask the board staff to respond to what was the motivation to take an audiology assistant category, or excuse me, an audiology aid, speech pathology aid, and make them an assistant with a license? What's the evolution of that process, if you recall?
You know, again, this is something that I came on afterwards. I do know that there was a need to, and I think speech language pathologists could probably speak more to this, but I think it was based on a need and demand for services and the limitations of an aid, because they didn't see an aid being sufficient. There was also some formal education involved, some formal education requirements. Having attended the national conference, that's still the case. On the national circuit, there's still other states that are going through what we went through 10 years ago in trying to create that SLIPA category. They were all rather surprised when I told them we had 6,000, because that's probably a significant number of the entire country's SLIPA population.
And I think if you're looking at the regulations, you know, the speech language pathology aid is similarly limited where they're assisting or facilitating while the speech language pathologist is evaluating the speech and or language of individuals or is treating individuals with a speech language and or language disorder. And so again, that aid is very limited to what they should be doing versus these SLIPAs that after, you know, education, field work, and then training, get towards doing a lot of therapies with the clients in a indirect or direct or indirect model where the speech language pathologist is not in the room, they're not over the shoulder, they're not literally in the room with them while the treatment is going on. So I think that's a very big difference.
So I guess two questions are, does the current language limit what the services that an audiologist would need to better meet their patient's needs? And is there a demand for going beyond the limits of an aid? Because I think that's what happened with SLIPAs.
And if so, that's what we would talk about
Right.
during the assistant conversation on Friday. But for this one, I mean, you do have language that makes the aid pretty limited, not completely clear for some items, but it does beg the question. And then it's not very defined on supervision and all the levels of supervision. You know, these regulations were made long before the SLIPA regulations. So I think sometimes it's somewhat easier when we see how clear the SLIPA regulations are, even though it's for a different license category with a higher level of responsibility and task. Just getting that similar clarification in the regs for the aid at the aid scope.
I'm not sure how to answer it in terms of the justification. There's an inherent difference between the service provision that an audiologist provides versus speech language pathologists, and a lot of that has to do with the environment or the location of services. Schools versus hospitals, et cetera. And my understanding with the SLIPA is one of the way it offered a lot of growth for speech language pathologists is they have these huge caseloads. They go and do the diagnostic workup for the clients, and they create the treatment plan. And now the aides can go and do a lot of that treatment plan on the day-to-day, across the schools, et cetera, to help with that client load. Whereas an audiologist, on occasion may have multiple locations of practice, but it's usually limited to a particular hospital or a particular practice, or, the need to have someone, to have aides out across different locations all over the place, maybe isn't quite the same as it is for speech language pathology. So is it that we feel we may need to broaden this category or broaden what they can do because we want them to be able to go to multiple locations? And if that's the driving factor, I'm not sure that's necessary. Whereas, in the building type of supervision would probably be appropriate in most circumstances. With the exception of industrial, I guess that's different, but I don't know. It's just very different. It's hard to say.
I think that's a good question, and that kind of that going back to the question of whether there is a need or demand, but I do think that there are limitations, and we'd have to really address those limitations by either expanding the statutory allowances or addressing the limitations and clarifying them in regulation.
I'm still stuck on the issue of what was the motivation to create a license type for speech pathology assistants, and rather than expand scope and define better the speech pathology aid category as we're looking at here. What was the motivation to create a license type? Was it this multiple location issue, or was it that speech pathologists needed their assistants to do a broader scope of practice that involved more consumer concerns? What made this become a license?
So I can't speak to the SLIPAs. I could go look it up and we could bring that information back to the next meeting. But I can tell you from other professions, when the boards have been approached by the professional associations saying, hey, we need to make this new license type because this particular act, maybe it's a standardized testing scoring thing that is something that somebody with a bachelor's degree can be trained to do. It's a standardized scoring method. There's no diagnostic involved with it. They're just implementing this type of specific testing that allows the higher level licensed doctoral level person to do the diagnostic parts and to do the truly complex evaluative functions and testing, but it allows them to free up their time and caseload to do that higher level stuff when some of the standardized testing can be done by a person that is licensed and also safe for consumers, but can do those lower level testing and get them out of the way. So, I mean, I've seen that where it was brought to a board and, you know, it would free up immensely caseload and allow those specialized licensees that are dealing with, you know, things like brain injuries to do more of the higher level stuff while trying to get a level that's for testing purposes. And literally even calling them testing technicians. So it just depends on the need. But SLPAs, we would have to go look at the history, and I'm sure we've got it somewhere.
I wonder if there's a difference there, Marcia, too, in billing. You know, obviously there's a fantastic difference between speech language pathology and audiology in what's billable, right? Audiologists can't really bill for any type of treatment services. So the whole process for oral rehab and hearing aids, et cetera, we can only bill for things like programming cochlear implants and more complex things. So does the SLPA allow, you know, by having them licensed like that, I wonder if there's an ability then for insurance to be billed for the therapies that are provided by the SLPA under the SLP, whereas in audiology, we don't, you know, that wouldn't really benefit us in any way. There's no way to bill for any of those services anyway. I don't know.
So for those things we can bill for, you think if they were licensed, we could bill for their services? Or it's
right now, as it stands, I highly doubt it. I wonder if on the SLP side, though, if that wasn't something that was tackled nationally again, I don't know. I'll be interested to hear from the SLPs. Are they allowed to bill for their treatment? I imagine they are when they're done by a SLPA. And in audiology, we don't have an equivalent. You know, we don't have that equivalent, that ability to allow, you know, an audiology aid to do pure tone air threshold tests for us and then bill insurance for it. In most cases, we can't do that, especially with anything from CMS. It has to be the audiologist. So that, you know, I don't know that we have the need or the reason to create that licensing category if it's not going to change, you know, our ability to bill for services, if that makes sense.
I mean, I doubt that would be the board's motivation to support that for that reason.
Oh, understood. Yeah.
It has to be, I think it has to be about consumer protection. And would licensing these individuals, thereby asking that they complete some sort of educational training program, that they have to complete CEUs, are we better guaranteeing to the public that we have their interests at heart and want to make sure that the care offered to them is by somebody who's competent, and that those measures historically have meant competency? You know, we could argue that, but that's what we're feeling.
Well, what we do know, Dr. Rajo and Dr. White, is that the current definition or the definitions of the speech language pathology aid would have greatly limited what they could do with aids compared to what they do now. And compared to what, I'm sorry, aids and assistants. And I think we all have to be really careful when we're talking about aids and assistants, because people that are members of the public probably might get confused. But the current definition of a speech language pathology aid would have greatly limited them and compared to what an assistant can do now and compared to the training qualifications that an assistant has.
Because they've had more education and, you know, they do have to do CEUs. Is that the motivation? Is that why you distinguish that?
They also have to do field work where they actually work on doing these therapies with clients. So they do have more of a focused curriculum and field work component. And aides don't have any of that.
But again, they're doing more long-term therapeutic tasks where their ability to treat the client and do the proper treatment, you know, yes, the SLP is going to come in and assess on a regular basis to see the progress, I assume, but they're working one-on-one intensively with these clients over and over and over, trying to achieve a particular treatment. It's very different than what audiology does. And I there's that equivalency I don't think is there, and the potential harm to the client or the patient or consumer from the audiology task is certainly, it's just very different than I think what we're talking about with SLPAs. And I'd like to make them equivalency, but I just don't know that we can.
I'm curious.
Yep.
Dr. White, in the same vein, I mean, the audiology aid is only allowed to assist and facilitate while an audiologist is doing something. Is there not, well, and I guess this is a conversation for Friday, but whether or not there's a need for somebody to be doing the hearing testing or something along those lines, the more routine stuff, and then providing you with the audiogram after, but it's probably for tomorrow. So,
Well, I'm not saying that an aid isn't useful. I can use my experience at the VA since I've been there for a year, which is we have health technicians in audiology, and they're extraordinarily useful for us there. The audiologist can do the complex tasks like a diagnostic hearing test, have the consultation to decide what type of device that patient might need, make that decision with the patient, and then pass the patient over to the technician, who then performs the ear impression, otoscopy before and after, ear impression. And same thing during a hearing aid fitting. The audiologist is doing the complex, real ear measurement, verification of the hearing aid, checking that it's comfortable for the patient, that it feels good, the sound is good, etc. And then passing them off to the health tech for the orientation, how to clean it, how to take care of it, how to change their wax guards, how to put it in and out of their ear, pairing it to their cell phone, etc. What that does is it frees the audiologist up, to see twice the number of patients they would normally be able to see, because literally half of the workload is not something that requires, the unique skills and whatever of a doctoral level professional. So it definitely has a purpose, but the purpose of an audiology aid, if it's going to be so limited to as well, you can only clean a hearing aid or replace the receiver, makes it almost useless. So it's like, either we need to allow these audiologists who are accepting this responsibility on their license to create their training plans and follow their training plans and submit those, and allow them to have a bigger measure of what those aids can do. Or if we don't feel that that's appropriate, then I suspect we should look into the different license type.
Just thinking off the top of my head about SLPAs and the vast majority of the work they do, I think is, and I could be totally wrong about this, but it feels like they are administering paper and pencil tests for articulation ability, maybe serially. They're doing language valuations. It's all paper and pencil things. It's not very consumer threatening, other than endoscopy, and I don't know how many SLPAs do or can do that. It doesn't look very dangerous to me, but I consider things like video otoscopy, making ear impressions, are all have the potential to be a little more dangerous than giving an articulation test.
Sure, but do we need to require, 18 units, 20 units, 30 units of education in order to ensure that doing otoscopy and impressions are done safely?
Well, we're saying that's the case for a SLPA to be able to do what they do, that we are requiring that somehow, that I presume the motivation was that assures or ensures to the board, assures them that they have the training to do these tasks. And we can feel comfortable as we've done our job protecting the consumer, because we're asking for licensure and we're asking for proof of competency. And we're not asking that of this other class of professional or semi-professional.
you're right, we're not asking for a formal education, but we are still asking for a formalized plan and implementation of that plan, and then making it the responsibility of the licensee, you know, as opposed to like a SLPA, right? The problem would be shared. If there was an issue, it'd be shared between the SLPA and the speech language pathologist, because they're both licensees. And in this case, with keeping them as an aide, the aide doesn't have a license to be held responsible. It's 100% on that audiologist, right?
Mm-hmm. I don't know if SLPs feel that if since SLPAs are licensed themselves, that somehow the onus is off them a little bit more on their license. That argument, though, Dr. White, makes me think about why we have a board to begin with. Why do we need to oversee these very responsible, highly educated, highly trained individuals? Why do we even need a board like this? Can't we trust these people? They've gone to accredited universities. They have these degrees. They have this education. They have this clinical training. Why do we even have to regulate them? Why do we have to have enforcement procedures? Why is all that necessary if we have responsible licensees out there?
Well, of course, because not all are responsible, right? So that's understood. But I don't know that just because not all are responsible as we would like means that, you know, the restrictions on what we expect them to be able to do and how they would train their aides, et cetera, you know, need to be onerous either.
But how about, I mean, I think, and I don't know the history of the SLPA evolution, but we want to hedge our bets that if we're going to let these people do this kind of work, that they need to have more substantial measures of competency under their belt before we can say, okay, we feel okay about it.
But if we had to identify the things that put the tasks that put the consumer at the most risk from an audiology aid and something the audiology aid might do, what tasks would those be? I know we've talked about otoscopy and ear mold impressions. Are those the riskiest tasks that they may do in terms of consumer harm?
I think tympanometry has potential.
Okay, and tympanometry. So if, I guess set tympanometry aside for a moment, if we were to consider that otoscopy and ear mold impressions are the riskiest things that an aid may do that may potentially put the consumer at harm, and we want to put parameters then on the training, then it, in my opinion, should probably line up with whatever training requirement there is going to be for hearing aid dispenser trainees prior to them doing that on patients, right?
I don't know if what training requirements there are. But
there aren't any right now, but I thought they were indicating maybe that was going to be a discussion later.
Yeah, it will, I'm sure, after this discussion. I guess I think if it's possible, Charisse, to find some of the evolutionary information about the motivations and prescriptive elements of developing the SLPA license, that would be helpful to me to get a better sense of how the equivalency issue.
And perhaps how the justification was made in the Sunrise application. I think, Marcia, you and I were looking at that going, oh, I wonder what they put for the SLPA on some of these answers.
Back in those days, they didn't do a Sunrise application.
Yeah,
that's a newer process.
Oh, man.
I can tell you when I was working at long time ago, working at the legislature, the idea of making sure things had sunrises and sunsets and not just, DCA boards, it was kind of a newer thing they were trying to implement. And this was almost 20 years ago now. So.
But there would have still been a great deal of justification involved. Yeah. I know that we can find a lot of that information. I also wanted to add, Dr. White, that we're talking about hearing aid dispenser trainees. A lot of the emphasis or the discussions has been regarding the supervision of trainees, the supervision requirements, not so much the training, because the only thing they're being prepared for is passing the written and practical examination.
Right, but their application to be a trainee, the dispenser has to sign off and say that they have a plan on how they're going to train the individual and that they've reviewed it together. They don't have to submit the
Right.
plan to the board, but there is supposed to be some sort of plan for training.
Right, but the discussions that we're having have to do with the level of supervision involved. That's all I was pointing out, that our regulatory language discussion, there is some discussion on training and on some of the topics, but really we've been focused on the supervision and the gap maybe in consumer protection there.
Can I just ask, Paul, what the supervision requirement is at this time for SLPAs?
I have two regulatory analysts who are working on those regulations, so they could probably talk about it. I know it's broad. Go ahead.
Yeah, I mean, depending on the duties, it can be immediate, indirect, and direct. Again, it depends on the duties, and we have a section that specifies the type of duties, and then we have another section that specifies things that are outside the scope. And so I believe that's what we're trying to see if that's something we need to do for AIDS.
I know that is defined real clearly in our board book here in the binder. I'm just trying to remember what section it was under, but it was provided.
And if you're looking inside of your book, they define levels of supervision in Title 16 CCR, California Code of Regulations 1399.170 is where they define the levels of supervision. In 1399.170.2, it talks about the types of supervision required for duties performed by a SLPA. And then in 1399.170.3, it defines the activities and duties and functions outside the scope of a SLPA. So they kind of tackle it by defining levels of supervision, telling what activities and duties belong at the different levels, and then what are outside of the duties of the SLPA.
Right, and so Dr. Raggio, to answer your question from reading it earlier today, direct supervision, immediate supervision with the right there with the SLP is required for medically fragile patients. And then direct supervision is required while the SLPA is still being trained. So they haven't yet, fully achieved their ability to do these tasks with the patient on their own. And then everything else is under indirect supervision. So there's only a direct supervision requirement while they're still in training. And there's only an immediate supervision requirement for medically fragile. And there are a few items that they're not allowed to do, like bolus swallow studies and vocal tract prosthesis, shaping, oral pharyngeal swallow therapy with bolus. Those are limited. They're not allowed to participate with that.
I think it's really interesting that we not only ask that these individuals be licensed and all the competency that requires, but then we put some guardrails around the activities they can do on top of that.
Yeah, there's only a guardrail for medically fragile and then the real swallowing study type of activities.
Well, not sure we can define here the medically fragile audiology patient, but we probably could do that. My point is that they're asking that these individuals be licensed and then create guardrails and levels of supervision and tasks that can and can't be done. The staff person who was talking, I'm not sure who it was, you were saying, you're working on those regulations now, but they're not in regulation yet. Is that correct? The things you just mentioned?
The SLPA is in regulations, and changes we are making to the supervision is that the first 90 days has to be 100%.
But those are
supervision.
Not in regulation yet, are they?
Not yet.
Why? What's your motivation for putting those guardrails in?
I believe for initial licensure, the desire was to have a higher level of supervision when they first enter the workforce.
And it's only for that when they first initially get licensed.
So that
But
makes some sense.
Their field work is only 70 hours right now, and it'll move up to 100 hours. So the field work is there, and it's an important critical component, but in terms of hours or weeks, it's nowhere near the other, like an RPE requirement. Yeah. It's all kind of gradients and has bumpers around each. So, aid, SLIPA, and then RPEs are the training category towards the SLP.
Okay. I think we've established the arguments pretty well here. It does ask for the action requested that the committee determine the direction of modifications or additions to the regulatory sections rather than discussing possible sunrise activities for licensure. I don't know if we can modify that action or how we would stipulate what kind of action we want to take at this point. We need more information, I think.
Dr. Raju, the audiology assistant is part of the regular board meeting tomorrow, so that can be discussed and acted on there. But we could, if we're not ready to make decisions on these yet, but you'd like to direct staff to go back and find some more evolutionary information on FLIPA licenses and their creation, that we can do that and bring that back to the committee so that we have a little bit more of a broad historical view of these things. My guess is that depending on what the board decides tomorrow about whether or not to refer the audiology assistant exploration to the audiology practice committee, that you'll probably talk about these issues at a future meeting as well.
Okay, so do we need a motion to ask that staff develop this historical information for us? Would that be our motion then at this point, rather than trying to take any other stand?
I don't know that we need a formal motion, but we'll assign it to staff.
Okay, we don't need a motion then?
No.
This is Michael. No, you don't need a motion to direct staff to perform certain functions.
Okay.
A motion's always in order, but it's not necessary.
Okay. I don't want to stop the discussion if there's something more any of the committee members would like to say. If there isn't any further board discussion, then I would like to ask the moderator to open for public comment.
This is the moderator. I've opened the Q&A panel. If you'd like to comment on this agenda item, please click on that Q&A icon, type comment into the text box, and submit that to our panelists. Not seeing any requests for comment, I will close the Q&A panel. And just as an FYI, Dr. Valdez has joined us.
Since he has joined us, and I don't know how much of the conversation he's been able, or the discussion he's been able to hear, but since he is a member of this committee, I would entertain any comments he'd like to make if you feel like you can.
I just got here, unfortunately.
Okay. All right. Well, you can join the conversation hopefully tomorrow. So I don't want to cut anybody short. If Karen, Amy, or Dr. Valdez, anybody would like to make any further points about this issue, I think we have at least a tentative direction to go. It's always good to gather more information, and that's what we're going to attempt to do, especially with something as complex as this. But are there any other comments?
Morsha, I don't have any comments pertaining to this, but I mentioned to you I have to head on out real quick since Dr. Valdez is here, so we still have quorum, correct?
Yes.
Okay, great. I'll be back soon.
Okay, thanks,
Thank you.
Karen. Okay, so since we have no motion, no vote, and I presume no further discussion? Amy?
Yeah, I was just going to say I appreciate the discussion, and I appreciate the monumentous amount of work it will be either way, but also that it's something that just needs to happen so we can get more clarity for everybody involved too.
Yeah, I agree. It would be nice to kind of do a once and for all kind of thing if that's possible.
Is that ever possible in regulation land?
No, I don't think so, but it's just a pipe dream. So that being the case, I'd like to move on to item number 5 on the agenda. That's discussion and possible action regarding audiology licensing requirements related to supervised clinical and professional experiences stated in BPC sections 2532.2 and 2532.25 and Title 16 CCR sections 1399.152.2. So Sharice and I have been working on this issue a lot, but she's in some ways closer to the process. So would you like to explain, Sharice, what we've been doing?
Yes. So we have been working on survey to ask the questions we went over at the August meeting. And we worked with DCA's Solid team to create a Survey Monkey survey. And it includes the 4 sections that ask about personal information, the program's perspective on clinical and professional experience requirements, the program's supervised professional experience requirements for their externship, and then the program's supervised clinical practice requirements for clinical rotations. And that survey went out to all California audiology program directors and clinical training program directors last night. And so we have that survey open and are hoping that we will get responses from both of the leaders of each program by December 31st of this year, so that we can kind of combine that information and use it to best determine how and if we are going to modify the regulations.
Okay, I'm sorry to do this a little bit backwards, but just to remind people what this was about is that you might recall that the previous statute said that RPs had to gain their 12-month experience post-didactic, that is, after they finished all their coursework. And that caused all sorts of problems for the programs and the students. So in our sunset review, we asked move the statement that all those hours and all that time had to be gained after the completion of the program, since there were a lot of clinical rotations that occurred earlier in the program that are 100% supervised and might be able to be used. So that's what led to our survey, to try to get information that would help guide how those regulations might, and statutory change if we do that, but regulations might be changed to allow, I guess, more flexibility in how time and hours are gained. And it looks like the survey is about 50 questions long. And we've worked hard on it to try to ask the right questions. And I think you mentioned not only of program directors, but of the clinical directors in each program, so we can get 2 perspectives from each program about the clinical rotations, so that we can develop pertinent, relevant, useful regulations on this issue.
And so hopefully we'll get a really good response rate to our survey, and then staff will work on combining that information to bring forward to the committee next time.
What's the deadline for returning it again?
December 31st of this year. So if they've got a couple months.
Hopefully we'll, and we did encourage them to ask questions in the meantime if they're unclear on something. So I hope to help guide them to get it in on time, if not before. Would be interesting. Is there any committee discussion on this topic?
I look forward to hearing all those survey answers. That'll be interesting.
Mhm. Any other discussion by committee members? Okay, hearing none, I'd like to ask the moderator to open for public comment on this topic.
This is the moderator. I've opened the Q&A. If we have any requests for public comment on this item, you can utilize that Q&A panel by clicking on the Q&A icon, typing the word comment into the text box, and submitting that through to the panelists. And not seeing any requests for comment, I will close the panel.
Thank you. Okay, I think that completes the meeting of the Audiology Practice Committee. So I will be adjourning this committee meeting. Perhaps we could take a 10-minute break before we start with the next committee.
Yeah, why don't we do 11 so that we're right at 10:20?
Okay, all right.
Go ahead and call roll, and then we'll get rolling. So Mr. Borges.
Here.
Dr. Raggio.
Here.
Ms. Chang. Dr. Valdez.
Here.
Dr. White.
Here.
You have a quorum and can begin.
Thank you. Okay, well, let's start off with open up the floor for public comment for items not on the agenda, please.
This is the moderator. I've opened the Q&A panel. If you'd like to comment for items not on today's committee agenda, please click on that Q&A icon, typically located at the bottom right corner of your screen. It looks like a question mark inside of a square. Type the word comment into the text box and send that to our panelists. Seeing no requests for comment, I will close the panel.
Thank you. Okay, so we have two items on our agenda today. The first item, which was a hand carry item, is review, discuss, and possible action on regulations regarding hearing aid dispensing trainees as stated in Title 16, California Code of Regulations, sections 1399.114 through .119. A discussion about trainees. That must be vaguely familiar to literally everyone on this discussion right now, except for me, since I believe you just went over all of that for audiology aids. Okay. So do we want to go through the summary of changes and then go through the discussion questions one at a time?
Do you want Maria to kind of give us some background?
Sure.
Hi, this is Maria, and I could, it's a brief background. In 2018, the board approved proposed regulation. And so in preparing the regulatory package for this item, the board staff presented to the hearing aid committee additional changes. And so in that discussion, further changes were made. And so the summary of changes are as follow.
So just so that everyone's aware, this hand carry agenda item was not able to get on the website ahead of the meeting. So we do have it displayed here, and I believe everyone has the ability to scroll on the PDF to review it as well. So if you're on the WebEx, you can scroll through the PDF as you follow along.
So the summary of changes, In working with our legal regulations legal counsel, we actually have decided to remove section 1399.114. And that's because the initial application, we're being encouraged to start incorporating our forms, application form into regulations. And for this particular license type, there is one piece that is not ready, which is the written examination. So the changes that we discussed were we did incorporate it, but we have pulled the whole section to be part of a different regulatory package when we're ready to, after the written exam has been promulgated. So that's that change. In 1399.115, we made it applicable to both license type for supervision and as well as the temporary, training and temporary license. We also noticed that there was a law that was cited from prior to the merging, so we did change it to cite just the actual section in the Business Professions Code. In section 1399.116, we did change it according to our discussion, which was to maintain the current supervision limitation, making it also applicable to both of these supervisors license type. And so we added language regarding the waiver process and specifying an effective date there to clarify it further. In 1399.118, we specify, we made the changes per the committee's discussion, which is to specify masking and speech testing technique, remove the term knowledge when talking about the real ear measurement, and then add another circumstance that could affect the duration of supervision, add record keeping requirements, and board staff, we added language regarding the supervision termination process, putting a narrative form, termination form that we have. So that's what we put in there. And then our last section that was changed was 1399.119. We made changes per our discussion. Legal had made some suggestions. We clarified the time frame after the first 90 days, specifying the licensing exams to include both written and practical, and then add the record keeping requirements. So that's a summary of the changes we made during the last meeting, as well as changes board staff identified regarding to forms.
Thank you. Does anyone have any questions regarding those changes at this point? Can we open it up real quick to the public, just in case anyone has any questions in the public?
This is the moderator. We've opened that Q&A panel. If you'd like to comment on the changes, please click on the Q&A icon, type comment into the text field, and submit that to our panelists. Seeing no requests for comment, I will close the panel.
Thank you. Okay. So let's just go ahead and forge on ahead to the discussion questions that were laid out. I want to circle back to question 1, if that's okay. I want to jump ahead, and let's jump to 2. Question 2 regarding section 1399.115C. Should the termination of supervision be specified in both sections regarding training, 1399.118, and supervision, 1399.119, or in one section? So you did change You did amend 1399.119 already.
Yeah, so for that question, because we do have, we're making this regulations also applicable to temporary license holder who fail an exam. Currently, the termination language is in the training, and that's only required for trainees, hearing aid trainees. And so we don't have that termination specified for the temporary licensees under the supervision. That I don't know if that makes sense. So I'm looking at, let's see. Oh.
So you're basically, in essence, asking, should we put it in both spots or just put it in the one spot as it pertains to both?
Yeah, if we're gonna keep it in one spot, I believe it's best to have it under 1399.1.
Through 119 instead of 118.
Yeah, it's currently in 118. And if we keep it there, we would need it in 116 as well, or move it to just only be in 116. So both license type can have a supervisor, but only one license type requires a training.
Okay, you're saying move it to 116, but in the notes it says move it to 119.
Oh, yeah, it can also be in there because it's related to supervision. Yeah, so yeah, we can move it there too.
Okay.
Sorry, my bad.
So the question is, do we want to consolidate it into one spot or keep it in both spots? Correct?
Yes.
Okay. My personal preference would be maybe to keep it in both spots just so that there's no potential issue of miscommunication and, well, I didn't see it, or does that pertain to me too? If it's not going to have an impact on anything else other than just an extra line or two. Anyone else have any thoughts?
Feels like saying it once is enough.
Yeah, I'm a fan of brevity. Not that you know it from listening to me talk, but
yeah, but once is enough, I think.
But if that in that one spot is clear enough and it's listed clearly for both, then I'm fine with that. Okay, so Amy, you have Dr. White, do you have an opinion on this?
Spelling error.
Pardon?
115C has a spelling error.
Okay.
The first sentence. I think it's their authority. The word there.
I agree. I think in one spot is fine.
Okay, sounds good to me. So it looks like we're in agreement just to keep it in the one spot for simplicity's sake. Question number 3. Section 1399.116D states that a minimum of 4 hours of continuing education and supervision training prior to the commencement of supervision. Is this prior to every supervision? Well, it does state that they are required to do an additional 2 hours every 4 years after that initial 4 hours. But for me, the question is, for how long? And what's the time frame? And then it would be, okay, well, it's been X amount of years since you've done it, so now you've got to do the 4 again. So we could either just say, yes, you got to do it 4 hours every time before you start to train someone, or we put in a caveat that the 4 hours plus the 2 is fine unless it's been X number of hours since the last time you've supervised someone, in which case then you should do the 4 hours again.
So for here, I think how you were going along is like the way it's written, it's 4 hours for every new supervision, or it's not clear if that's going to be for every new supervision. So I'm not sure if that's the intent of the initial that 4 hours.
Essentially, every time you get a new trainee,
You have to do
then
4
you gotta
hours.
do 4 hours again.
Yeah.
I don't think that's what you were intending, what the committee intended.
Yeah, that seems an overkill.
I don't believe that's what the committee intended. I'm wondering if it shouldn't just be, I see what you're saying, Todd, if you want to say, okay, if you haven't supervised in more than 4 years or something, then you have to start over, or is that what you're asking, if we need to have some sort of time frame in there?
Well, yeah, that's just the question, kind of, looking ahead, playing devil's advocate a bit, because it does say that they have to complete 2 hours of continuing ed in supervision every 4 years thereafter. But how is that checked? I mean, if I do it and I supervise someone and I do it and I decide, wow, that was a horrible experience, I'm never doing that again. And then 6 years go by and I think, I'll give it another shot. Okay, do
I would imagine you'd have to repeat because you hadn't kept up your 2 hours every 4 years thereafter.
Well, and where is that checked? How do we know that they've done that?
An audit would be a CE audit would be performed, and if they're identified as supervisors, the CE auditor would check to see within the last, depending on where they're at in the phase, like have they completed 2 hours or the 4 hours. I guess my concern is the overkill of the 4 hours, because right now it's saying that with each new supervision, you have to complete 4 hours. So it's like a person's completing 4 hours, like maybe every year if they're having a new trainee or something.
Yeah, and that's way overkill.
Yeah.
I don't think that's necessary.
Because I think what the intent was maybe something about upon
initially taking someone on.
Yeah, essentially, the first time you become a supervisor, you need to take the 4, and then every 4 years after that, you need to take 2.
Right.
Can we pull how it's written for RPE supervisors?
That's what I was just going to start looking at, if I could pull through my binder.
While we're thinking about that, I just wanted to mention that Karen Chang is back with us.
Hi, Karen.
Hi, thank you. Sorry about that.
That's all right. We saved all the really boring stuff for when you got back.
Thank you. I'm just
Okay.
reading up now.
No worries. So if we look at the RPE requirement that is in the regulation 1399.153.3, it says the required professional experience supervisor must have completed not less than 6 hours of continuing professional development and supervision training prior to assuming responsibility as an RPE supervisor, and 3 hours of continuing professional development and supervision training every 4 years thereafter. And then it just talks about board-approved providers. So I think you could try to mirror that, but with a different numbering system. The 4 hours instead of the 6, and 2 instead of the 3.
But I like that because then it's tying it more to the licensee as being a trainee supervisor, that you're assuming this role. It's not tied to when you get the trainee or having a new trainee. It's just, if you're going to supervise trainees, you're going to complete this.
If there's a lapse of 5 years from the initial training or CEO, you'd have to retake it unless you maintain the every 2 year.
Well, I think it would be a lapse of 4 years.
The
since
The
you have to do
current
the
regs in the
two
RPE don't have
every
that either.
4.
No,
Okay.
yeah, I think the regulations, I think for RP and maybe FLIPA is kind of also in the same boat where it's like, technically they have to do the CE training for every supervision form we get, essentially, and track that.
It's just prior to assuming an RPE supervisor role. So once you've assumed the role,
It's in the rule.
then you're good.
Wait, what was that language?
It's a G of 1399.153.3. So you can use 0.153.3 G. I don't think any of the regulations had envisioned a lapse of supervising, like if you stop being a supervisor for a while. But that could be something that you add to there.
I'd say, well, we have the opportunity, we should add it.
So add
Yeah.
a provision that if there is a 4-year lapse, or I don't know if lapse is probably the wrong word, but if there's a 4-year span in which the supervisor is not performing supervision duties and not taking the continuing education, then they would have to do the 4 hours. That's what you're.
Does it have to be both?
I was
If-
just going to say, couldn't it just be if they haven't? Yeah.
I was gonna say, it kind of seems like if they're willing to maintain the continuing ed every
Yeah.
2 year, the 2 hours every 4 years, if they're maintaining that, even if they don't have someone to supervise in that time frame, I don't know that we would want to make them repeat the initial 4.
Because doing the 2 is basically telling us that they want to maintain a supervisory role at some point.
Right.
So, yeah, I would think it would just be if they don't do the 2 additional hours within that 4-year period, then they have to start from scratch again.
Yeah, I would agree.
We only do 2 hours in the fort?
4 hours initially and then 2 hours every 4 years after.
Oh. 2 hours every
That's the way it is currently written.
2.
Does everyone like that?
And
Yep.
Maria's noted the change to add to it.
Okay.
Yeah.
Okay. So number 4 for 1399.116D, should CE record maintenance for this requirement be different from the CE requirements? Then they listed what it currently is for each. Now I had a note written here, and now I don't even know how I came up with that note.
Does the requirement make sense if the trainee is every 4 years?
I think that was my note was, should it be 4
Maybe
years
that's
given
what I
the
was
length
thinking
of
is like, well,
time?
if they have 4 years, it means they don't technically have to keep it.
So is it worthwhile to add a record keeping for 4 years?
Yeah, because that's the distance, so that's the length of time that they can go before they have to do it again. I don't know how we could not do it every 4 years, because then you wouldn't have record of whether they did it or not. If they did it in year 3, you may not have record of that. So I would think that the record keeping should be the length of time that they would have to then renew the the
It could also be like
education
a
requirements.
year, 2 years after the renewal period.
I think you just need, because they did, all of the supervisors renew annually, so 4 years at, keeping it 4 years following the renewal period in which it was earned is something you can do.
Okay.
So.
Yeah.
And then if they're selected for audit after that renewal, that should catch it.
Okay, yeah, I think that was my concern with the auditor. If it's not clear, the auditor there might not be documentation for the auditor to confirm it.
They'll have to be on top of it fast.
Anyone else have thoughts on that? Did the last discussion on trainees go so long that it just beat you guys all into submission?
Yeah, this is just fine-tuning questions since I've been working on the initial statement of reason and just making sure that I understand the intent of the committee and board. And so, yeah, this is just fine-tuning some of the language and just getting clarification.
Cool. So then number 5. Not sure I know how this might violate. BPC section 2538.30 states that temporary or trainee licensee shall not be the sole proprietor of, manage, or independently operate a business which engages in the fitting or sale of hearing aids. Do the supervision requirements in section 1399.119 reduce the likelihood of violations to this code? I'm not sure how those two. I'm not sure what you're asking there.
So I think the concerns was that the current regulations kind of allows them to operate freely. And so just going back to you guys as you're looking at the language in its kind of its final form, does that reach that goal where we aren't going to see those violations that we're trying to address?
Where essentially the trainee is the only person at the branch and they're operating essentially by themselves. Right, I believe that was the concern.
Yeah, and so I guess if you follow up to the next question, that kind of gives some examples of situations maybe where some issues can arise. So like what happens to the trainee if their supervisor is sick? Like should we have language regarding multiple supervision? I'm not sure how business is operated for hearing aid dispensers, but yeah, that was one thing I thought about. I was like, well, does that mean a trainee can't work because their supervisor that is assigned to us is sick? Should we have multiple supervisors?
So this is Paul. You don't think that the statutory language is enough in that it says that they can't independently operate? And would we define independently operate as being there by themselves without a supervisor?
Fitting and selling hearing aids.
Right. No.
I think that was the question.
I guess the question is, what do you mean by independently operate a business? I mean, because there's a big difference between owning the business and independently operating the business. Those are two theoretically entirely different things.
This is manage.
And if the trainee is under the 80% supervision or the 20% supervision, then yeah, there are going to be days where they could theoretically be by themselves.
So I think the question about what if someone is out sick or on vacation, isn't probably of significant concern unless they're in that first 90 days where 100% immediate supervision is required, right? Or first 90 calendar days.
Well, given the likelihood that someone is in a sole proprietorship being trained, there is no other person that they could pass that off to. Because if that's a sole proprietorship, they're the person who's training them is the only person in that office if it's a one man or one woman office. So
right. So if they're in that first 90 days, are we saying that if the licensed dispenser is not available to be there during that time frame where the trainee is supposed to be 100% supervised, then they cannot see patients that day, correct?
Yep. That's how I see it.
I agree.
100% 100%.
Well,
Now there are possibility. I mean, do you guys, is there a way with the board for someone to register as a secondary supervisor when someone's has their training license? I mean, usually you have one person who agrees to be their trainer and they sign the form, right? Saying, yep, I'm going to take responsibility. Do we even have a vehicle for someone to step in that situation? That would be directed to Sharice or Paul.
our apologies, we missed that. Can you restate the question?
Well, one of the questions is, assuming does the trainee need an alternate supervisor if they're unable to work due to sickness? As Dr. White and I were talking, if it's during the first 90 days, 100%, that trainee just doesn't work until their supervisor is back. But then my question was, is there even any way to designate an alternate supervisor? Because my understanding of the paperwork, when someone files for their trainee license, they have a dispenser or a dispensing audiologist say, yep, I'm going to train them. They sign the paperwork and says, basically, I'm their sponsor, I'm their trainee, I'm their trainer. Is there anywhere on that paperwork that allows for the designation of an alternate?
There could be similar to RPEs where we allow them to put a secondary supervisor. The one thing I would mention is that in 1399.119F, that first 90 days is immediate supervision, but that last sentence says that the supervising dispenser, after the first 90 days, the supervising dispenser provides direct supervision. And our direct supervision definition says the dispenser is still on site. So if the dispensing supervisor was sick, the supervising dispenser is sick and not available on site, even direct supervision isn't available. So
he's asking if is there language that would allow a substitute?
I think we would want to add that similar to the regulations about multiple supervisors in RPE.
Yeah, currently we don't have regulations for trainees regarding multiple supervision. So we don't require that on the form. We don't ask that at the form. But if we do, in regulations say you can have a multiple supervision so long as one is designated as the primary, then that would allow us to add that on the form.
So obviously I don't think you could stipulate a name that the trainee would have to state the name of that person because he wouldn't know. So it would just have to be an alternate licensee.
And currently, the way RPEs do that is they submit a supervision addition to us, and we process that.
I don't know how common it is for hearing aid dispensers at their locations to have more than one hearing aid dispenser.
Not very common.
Okay.
Well, the requirements are so different right now that I don't think it would be necessary, but with the new requirements, it may become more common.
Yeah, because what I guess for me is like technically how the regulations we're proposing is like the hearing aid trainee is going to be out of work if something were to ever happen to their supervisor.
Or the business may be hindered from operating.
Yeah.
So I understand that it has to be direct supervision after the 90 days, but whatever happened to it's the 80/20?
Right, I was just gonna ask that, Todd. I don't see
So
where it's required 100% of the time.
Okay, so that's what was changed back in November 2018 was to remove the 20% direct supervision because it means that 80% of it was indirect, and that indicated maybe they were independently operating.
And this committee also reviewed that language recently.
Yeah, and that's what we presented. We brought that back. So that's how the change to this section occurred, was because of that concern that 20% direct supervision wasn't sufficient to prevent that from happening. So
these regs move away from the 80/20.
Okay.
So I'm not sure I feel that it's a problem that the trainee can't do patient care while their trainer is out sick or on vacation. They can do other activities in the business in terms of answering the phone and scheduling or cleaning something. But, I think the whole point of being a trainee is that you're not operating independently, that you have someone right there supervising. That's what we're getting at, right? And it's a commitment. It's a big commitment on the part of the dispenser, just as it is on the part of an SLP or audiologist taking on an RPE. I don't know. What do you think, Todd?
I think that's a good point, Dr. White.
No, I agree completely. I mean, if you're doing it, you're responsible for that person, and that's your license now on the line as well. So if you're going to do that, then you have to commit to that.
And unlike RPEs, there is no, I've already had a bachelor's and a master's or a doctoral degree, level of education going on. I have potentially no specific education in this field. So I think that is one of the reasons, we're looking at tightening this in the first place.
I would just suggest then that I think when we asked about whether or not there should be a definition of indirect supervision, that we would want to bring that back so that it's clear that if your supervisor is sick, you could have the store open, or you could have your branch open and you could be doing these limited things, but you can't be doing things that require direct or immediate supervision.
Well, what it comes down to is you're not required to generate income.
Yeah, you're not functioning.
In essence, what it is, because you're not testing, you're not
Right.
fitting. So yeah, in essence, you're doing non-income generating tasks.
You're doing clerical work.
Yeah, cleaning checks and things like that. But yeah, you're not. And I am fine with that. But what it comes down to is this with the alternate supervisor, because that's something that's really brand new. I don't know. In practice, I don't know how realistic that is, because so many places are, one person, one office.
What would be the percentage of those places?
99.9.
Wow.
There are some offices that will have multiple dispensers in them, but I would say that's maybe I was exaggerating. Maybe that's 5%. But there are, for instance, if you're working for a large company, you could conceivably, if your supervisor is on vacation, you could conceivably go to another office and work out of that office.
Right. And that's what I was going to say, Todd. I think at least with our RPs and audiology, on occasion, it's, they got part-time, they have someone that's able to do it part-time at this clinic and someone at a different clinic. It may not even be the same company that's willing to do it the other time. So, but both supervisors have to have that, education. They have to fill out the form and
Yep.
submit it, and they have to, they're just as responsible. They're not just like a backup. We could just fill it in with anyone. It has to be someone else that is responsible in terms of doing their continuing ed and supervision, et cetera.
Well, and I think if we're not allowing for indirect any longer, then I think it's necessary. I think we have to be able to give them the option of having an alternative supervisor so that they're not necessarily just sitting on their hands.
Agreed, but I think it
over a
has to be
period of time.
predetermined like it is in the RPE where they're,
Yeah.
Yeah.
Well, and that's the point I'm getting at. Yeah, I mean, the form, what they're filling out now kind of has to be changed or altered, right, to account for that. Or there has to be a secondary form so that if I'm a trainee and I find out that my supervisor is going to go on vacation for a month to the Bahamas, in 6 months, I can find an alternate place to go. And if that person's willing and will do what they need to do, the 4 hours of continuing ed and all that kind of stuff, then, I should be able to fill out a form and have that person added after the fact, not just at the time that I am designating, who my supervisor is. Does that make sense?
Yeah, I think that we can add a provision about multiple supervisors in here somewhere, and bring that back next time so that they have the opportunity for multiple supervisors, so the secondary supervisor can come along, and that way they'll be able to do direct or immediate supervision if needed.
So then we'll have to see how that lays out then down the road.
Yeah, because that kind of goes, so you were saying that in that situation, they would have to go to a different branch?
They might.
Yeah. Theoretically,
okay, so
yeah.
With a different hearing aid dispenser?
Yeah.
So they'd have to specify the location, the other supervisor.
Yeah, because that was the next question is it common for trainees to work in multiple locations? Because we do require that licensees provide us branch location. And so I kind of need an idea if that's common, because then that's something we need to do in regulations. We don't have, there's a form we require that we don't have in regulations.
I think, from my experience in having many RPEs over the years, it's a really nice flexibility for the trainee to have, because they may not find someone that's willing to take them on 5 days a week or has the ability to do that, but they may be able to piece together a full-time training if they have it at 2 different locations with 2 different mentors. So I think it's probably worth allowing that flexibility.
Well, if we're not going to allow for indirect, I think it's pretty critical, because that can really stymie someone's training.
And then, okay, so yeah, next time we'll bring language that will include regarding multiple supervisions and then branch offices working at multiple locations. And so we'll work with our legal to figure out a best place to put it and how to approach that. And then the final question is just a wrap up. We have a list of definitions for each division. And so I went back in there and looked at it. And so I wanted to kind of, it's probably going to be a different packet since it's being amended somewhere else. But I just wanted to briefly have the committee look at those definitions and see if they align to the changes we're making and the intent. So number 6, I just wrote down the definitions to the supervisor, supervision, trainee, applicant right there. And I'm suggesting currently for supervisor to also mean supervising dispenser. With this one, I think I want to see if the committee, currently how it reads is that if someone is like a temporary license holder, they can be a supervisor. That's what 2538.27 is who they are, if I'm not mistaken.
So a temporary license holder is someone who essentially has a provisional license in the state until they pass the test to get their permanent license.
Yes, they're out-of-state hearing aid dispensers,
And they require supervision.
and they could require supervision if they fail. So I
Right.
think that's
So then
one.
we don't want them to then potentially be a supervisor.
Okay, so that I just wanted to make sure that the intent, because I
That
did
would be
that
that
in
because that could get a
illustration.
little weird.
Okay.
Does everyone agree that, the person should probably have their permanent California license before they could supervise a trainee?
Yes.
Yes.
Absolutely. Yes.
Okay, thank you.
And with that, we are going back, making sure that it's also applicable to dispensing audiologists. So referencing they are licensed under a different section. So yeah, so that is something we're also making sure is also clear that a supervisor can be either a hearing aid dispenser or a dispensing audiologist.
Okay.
Since if looking at 6C, a trainee does learn how it's in that environment where they learn to do um, hearing testing and masking, word recognition, all of that as part of the practice. Do we need to stipulate that at all, that they're not just fitting and selling hearing aids, but they have to do the underlying audiometry?
I thought we did actually stipulate that.
Yeah, so in the
Or we-
definitions, we define training to mean the instructions of a trainee applicant in the fitting or selling of hearing aids. We have had made changes to that entire section. So it may be something the committee may wish to consider redefining training.
Well, I think you just need to change one word in there, it's all. Because if you talk about the practice of fitting or selling hearing aids, that statute talks about the rest of it. Right? So
Okay, that's okay. That's
Yeah, I know I saw it listed.
yeah, I think it's just in the terminology. We just might want to clarify that it's the practice of fitting or selling hearing aids,
Okay.
which that definition in 2538.11, that kind of helps clear that up along with hearing screening.
okay.
That's all. I think without that word, it looks like you're just talking about fitting and selling hearing aids. But if you say the practice of fitting and selling hearing aids pursuant to that statute, then I think you're clear.
And then that circles us back to question 1. Are the requirements in section 1399.115A and B in alignment? Should we just say sure?
Yeah, so both sections, they kind of say the same thing, but in opposite, if that makes sense. Like it says in 116, they shall have, and then in 115, it's like
One speaks in the negative, the other one speaks in the positive?
yes.
Right.
But it kind of has, I think, there's a couple like terms missing in one or the other. So I just want to make sure, like, do we want to make them the same?
Is there any reason why we wouldn't want them to be mirrored?
I probably don't just want to cross-reference it.
They're currently they're both currently, it's not cross-reference because when this was created, they were both added to the text, so that's currently how the text looks like. So yeah.
I mean, because if the board shall refuse to approve if they don't meet the requirements in 0.116B. They don't. So it could be just a sentence that says the board shall refuse to approve the supervising dispenser's authority to supervise a trainee applicant. B through C, you have too many or you qualify. Does that kind of just make it easier so then it's just a cross-reference? Karen, do you have any concerns about that? Our regulations council?
I'm trying to chew it through and I don't think it's a problem. Obviously we're going to look over all of these changes closely before the text moves forward to the board.
No takes backsies.
I think in one of them, it says consecutive, and then the other one, it doesn't. So I'm wondering if that term should be added to,
Yeah, if you want them to be parallel.
I think you do want them to be parallel, and I think for that reason, you should just cross-reference it. So
yeah, so
same requirements for approving an initial request to supervise would be the same for the board can refuse to approve you because you don't meet that criteria.
yeah, the board approved changes where one of the 3 years is consecutive, but then in the other section, it's not consecutive. So I wanted to make sure, like, should that also be reflected there?
I say you just cross-reference it, yeah. Make it nice and clean.
Okay.
If the board's okay with that, if the committee's okay.
Sure. I'm going to go back to my initial comment. Sure. And I apologize. I meant to do this halfway through because we actually went through quite a bit in a relatively short time, and I wanted to, get questions from the world out there. But if we could open it up now for questions concerning anything that we just discussed before we move on to the next topic. Thank you.
This is the moderator. We've opened the Q&A panel. If you'd like to submit a comment regarding the discussion, please click on that Q&A icon, type the word comment into the text box, and submit that to our panelists. And if you are a calling user, you can dial *3 to raise your hand. And seeing no requests, I will close the panel.
Thank you. So moving on to
I'm sorry, I take that back. We had a comment pop in right as I was getting ready to close it.
That'll teach me.
Linda Oliver. Okay, Linda, I see you have about 3 connections. I'm hesitant to open them because we will likely end up with a very bad echo chamber. So I'm going to read your comment that you wrote in the text box. It says, is there a stipulation as to how many years experience a supervisor needs to have before taking on a trainee?
Yes, that was the area I was talking about. So on page 3 of the text, 1399.116B1, it states that the person has to have engaged in the practice of fitting and selling hearing aids for at least 3 consecutive years prior to the commencement of supervision.
Okay, and that was our only question, so I will now close the panel.
I'm going to wait a second. I'm going to have you fool me twice. Okay. So moving on to our second agenda item, number 4, discussion and possible action to amend regulations regarding hearing aid dispenser advertising requirements as stated in Title 16, Section 1399.127. Okay. Would you like to give us a little bit of the background and the summary of changes on this as well, please?
Yes, so on August 22nd, we're looking at proposed changes from 2017 regarding hearing aid dispensing advertisement. The hearing aid committee did look at this last meetings and touched on some items that we were able to maybe incorporate or clarify. Yeah, so the summary of changes were grammatical corrections and revisions to A and B. And C and D. Yeah, C and D. For E, so I did work on the initial statement of reasons on this one. So I was able to come up, I had to kind of rearrange certain things to, I think, meet better to what the intent of the regulations are. So that's where, towards the end, especially in D and E and F, that's what the changes that I did. Let's see, so for doctor, we spelled out the term doctor because that's how it's used in statutes. And then we combined what was originally the previous section to increase clarity. So there was a lot of like redundant language in this text that was causing a lot of confusion as I was justifying, why we're requiring this requirement. And so that's what happened with D, E, and F, and G. Again.
Thank you.
Yeah, so the questions are there just to clarify some areas, mostly follow up from the discussion we had started. And so I think for the first one was does the proposed regulation prevent audiologists from calling themselves doctors without the designation of AUD? And I think that may be one of the reasons why we're removing the table, because the tables really specify like PhD and like a certain way. And so I think with the regulations language that's being proposed, I think that's where it will be okay to use that designation. Like it's not. Because I think I'm assuming AUDs are like a new reg term designation for degrees, or
Not too new. They've been a while now, but
New compared to these regulations, yes.
Yeah.
New
Compared to the regulations. Okay, so when the regulations were created, I believe it was predominantly PhD audiology, but now we have AUD, which is different from PhD, which can be different. But so yeah, so I think that was a question that was posed, and I wanted to go back and clarify that with the regulations, it would make it clear that yes, you can use that designation.
The main point being, you just have to make sure you're specifying the field in which the degree was earned. So you just can't call yourself Dr. Todd because I got a PhD in animal behavior studies. And now I'm a hearing aid dispenser, but I call myself Dr. Todd, and everyone assumes I'm then an audiologist.
I remember we used to have to stipulate what, if you said even PhD, you had to designate what it was in.
Yeah. So in the text, if you see in the text on page 2, you kind of see what was striked out from regulations. And so regulations is saying if you have a PhD, you have to say in audiology or in parentheses audiology. But when you have an AUD, that's already in there. So you don't necessarily have to say AUD audiology.
But does it say just doctor or it has to say AUD?
You can't,
because that's a big difference, especially for patient fronting things.
Well, it says in the new regulation, other than physician or surgeon licensed in the state, the title doctor or any variation of this term without specifying the exact field in which the doctoral degree was earned. So
Yeah,
you
so if
can't,
you
so you
refer
have to say what the degree is in, as opposed to giving 14 different examples of what it should look like.
Yeah.
You're just sort of distilling that down to a sentence that says you got to say what it's in.
Yeah.
Am I correct in that?
So you have to say AUD, or you need to say PhD in audiology.
Mm-hmm.
Right.
Some of us don't have PhDs in audiology, but.
Well, and I think that's kind of the whole point of requiring it so that it's more specific, which I think makes sense.
You can have audiology is very limited. You can have auditory neuroscience. You can have a lot of different designations that have to do with hearing.
Do we think that's sufficiently covered then on that one, or are there still concerns about that?
If there aren't any questions on this matter, we can move on to the next item for discussion, which is the subsection D4 regarding the advertisement of hearing tests need to be clarified.
Let's go ahead and move on.
What page is that? What are you referring to?
The text is going to be on page 4 at the very top.
Not page 4 of the memo, but page 4.
Yes, not page 4 of the memo. Page 4 of the check of attachment.
Okay.
A.
So once upon a time, there was very specific language that we had to use when advertising hearing testing.
Yes, that's correct. And so the reason why I'm bringing this up is that this section is also applicable to dispensing audiologists.
Mm-hmm.
So I want to make sure that it was clear for like you as practitioners in the field, like that language is like clear that what it means.
So this is allowing people the way it's written, it's allowing for some poetic license, if you will, in how you say performed in order to fit and sell a hearing aid. It just has to say, we're doing this to sell and fit a hearing aid.
Cool.
which I think is, I mean, the way it's written, I think it's appropriate. It's essentially saying the exact same thing that it said before.
Sorry, this is for dispensing audiologists also?
Yes, the way the language of the text is written, it starts with a person licensed to dispense hearing aids may advertise the fitting and selling of hearing aids.
But
Advertising.
but
On the first
dispensing
page of the
audiologists
text.
do a lot more testing other than just the selling and fitting of hearing aids.
Yeah. Inherently, they do.
Yeah, so, I mean, the reason for that language originally was to differentiate dispensers from audiologists.
That's right.
So that way, I wouldn't be presenting myself as doing more than anything other than testing for the purposes of fitting you with a hearing aid.
Why can't we just stick with the original language? This is Karen.
I think this is just one section that you can't really resolve between dispensing hearing aid dispensers and dispensing audiologists. I don't think you can necessarily bring those two together in this one particular point.
I think in the past, we probably need to look at this a little more closely because audiologists do have within their scope of practice testing, and that testing doesn't have to be associated with the sale of hearing aids.
Right.
That's right. It could, but it is.
Not necessarily.
Right, but it's not limited to that. So I don't think that a restriction like this would apply to audiologists.
Yeah, so that's why I brought this question up, because that's, I wouldn't want to move this packet forward if this language isn't clear enough to, distinguish those issues or the two license types.
Well, it would be clear if we put in something in the language that says that pertains to hearing aid dispensers.
You could almost keep it the same, number 4, and offer to perform a hearing test by a hearing aid dispenser that does not clearly state the test is being performed in order to blah, blah, blah.
Right. Now, the second section that talks about services as part of a research and or field study that does not violate this section if no selling of hearing aid occurs following the research or study. I don't know. That's new to me, and I don't know how that pertains necessarily to dispensing audiologists. If they in the past have been allowed to sell a hearing aid after a research or a study, or if that was always verboten.
It was a problem, not just for dispensing audiologists, but for dispensers in particular, who would say, we're doing a research study, we need 30 subjects, and
Right.
we'll try this product. And it was really just a scheme to get people to come in and buy the hearing aid, which they'd always promised to be somehow less expensive if you participated.
It's a marketing ploy.
It's just a marketing ploy, yeah.
Yeah. But the question is then, should that marketing ploy then be disallowed for everyone?
Yes.
I think
It
it
applies
was,
to
yes.
Right. So therefore, that section does actually pertain to both dispensing audiologists and hearing aid dispensers. So should that maybe be pulled out, and that should be a separate item?
I would agree.
Well,
The second part of that sentence. So we're looking at splitting that and making their own provisions. And then for the offer to perform hearing tests, that first part of the sentence to be strictly for those licensed hearing aid dispensers.
I wonder if we could add language that says unless the licensee is authorized or unless the person's a licensed audiologist, something.
Yeah, or holds an audiology license, yeah.
Yeah.
Yeah, I mean, it serves the same function either way. Either put hearing aid dispenser in front of it, or unless you're a dispensing audiologist in the back of it, it's same thing.
Do audiologists put ads out there offering free hearing tests?
Yes.
Is anyone aware of that?
Yes.
That's where that 3PA thing comes in too.
Mm-hmm.
That's part of their prerequisite. Most of us don't honor it, but
Well, right. And then, they're not supposed to if they're contracted to Medicare, but that's, outside our concern.
yeah. Mhm.
Okay, so are we good with changing number 4? Did that answer that? Does that clarify question 2?
I think that clarifies it.
Okay. So question 3.
Oh, so this is just a follow-up on the discussion regarding verifying the accuracy of the dollar amount, the non-discounted and actual price. I'm not sure if we want to continue the discussion on that, and that's related to the next section, the next provision requirement.
Well, I have to say, when I read the question and, how do they verify the accuracy? And then when I read, what it talks about, I ask myself, yeah, how the heck do they verify the accuracy?
They don't.
Yeah, I mean, it doesn't really kind of specify it at all.
It's like asking, to verify the dollar amount of any other consumer product.
But then that's
I think
part of the problem.
wasn't the point of that language to require the regular sale price in the same ad? So you can say, here's the discounted price, the regular price is X. And of course the consumer can't verify that reported regular price is the regular price. But if there were ever a complaint, could you not then go back in and look at sales receipts for that device and what the normal price is to verify that was accurate?
You could, but you're right, Amy, that it's that original price that is inflated and the discount isn't real.
Yep.
We were trying to get at having not some high in the sky MSRP that no one actually uses be reported as the price in the ad. But there's no way. I mean, how do we make sure that that's the case?
That's how it used to be, that they had to list the MSRP.
Right. And now the MSRPs are, at least in my experience, really inflated by the manufacturers to make it for all sorts of other reasons, for billing with insurance and all this other stuff.
Yeah. Well, half the manufacturers won't even give you an MSRP anymore because they don't want to get caught in that web.
Yeah, you're right, Todd.
They tell you, do your own. And so people are making up their own on the spot. Right. Did you have a question, Karen?
Yeah, well, I was just wondering, MSR, if the manufacturer's not giving you MSRPs, then, any hearing aid could be just any random price, right? Like if I'm looking for, I don't know, a car, they'll give you an MSRP price, but sometimes you can go to someplace else and it'll be a different price.
And I think that was the challenge, Karen, was that in a lot of the ads, it may say, if you come in between these dates, you'll get a 50% discount. So the hearing aids are going to be $8,000 for the pair instead of our normal price of $16,000 for the pair. But in reality, they never actually ever sell those hearing aids for $16,000 a pair. They're always $8,000 for the pair. So it was trying to make some sort of the ask, right, is to try and make some requirement of what is your actual for real price on the non-sale day.
Is there, I mean, realistically, is there any way that we can regulate this?
I want to ask a question too from Dr. White. How would we verify that? Like if we were looking at, how do you think we would verify, Dr. White, that that is a inflated price?
You would have to pull their purchase agreements and say, show me all the purchase agreements for the last year on this model of hearing aid and see if they ever charged anyone $16,000 or if it's always $16,000 minus your $3,000 AARP minus your $3,000 you live in Elk Grove or whatever, you know, to see if they ever actually charge anyone that or with any regularity.
So that would be one way of providing verifiable data.
But is that to the consumer or is that to us upon complaint?
That would be data.
I have a quick question. What about the recent, what is it, the Transparency and Pricing Act or whatever it is, where now you have to actually list your prices and make them visible to the consumer? It was a recent Fed regulation that came down, I think, in conjunction with the OTC stuff.
That just has to do with whatever you are going to be charging that consumer. They have to be made aware and given X number of days notice that that's going to be the charge. It doesn't require that you tell them that of that $16,000, $12,000 of it is profit and $4,000 of it is hard costs. It's just telling them, informing them of what their price will be.
Right, but it is listing the price of the item. I mean, I guess you can put down whatever you want and say that's the price, you know, which is the issue we have now with the bogus MSRP.
So I would agree. I think Sharice or someone had said, well, then is that really the consumer verifying it or not? No, that would be
Well, and the only way the board's going to verify it is if someone files a complaint, and then you guys do an investigation, and you know, I mean, it's only like everything else in our business. The only time anything is actually verified is if someone files a complaint, and then that triggers an investigation. So
that's true, and I think in answering Sharice's question, my response was, it just says it has to be based on verifiable data, not that they have to advertise that. And we've had cases where we do investigate and we find out that the other price that they were comparing it to was a bogus website that they made up themselves. And they were showing that to people. So we were able to discover that through our investigation. And I was just curious if any of you knew of any other ways that we could verify this. As an example, it sounds like the language is good the way it is, that it should be based on verifiable data.
Probably the safest thing to do is leave it that way, or the only thing you can do
Right.
pushing it further.
It sounds like there is no MSRP to link to.
No.
Or at least most manufacturers aren't going to give it to you.
No. Okay, so then in retrospect, the language is fine the way it is.
What about part about actual cost?
And additional, you're talking about extra cost in addition to the hearing aid?
No, it didn't. Never mind, that was just in the question, it's not in the reg. Okay, I'm okay, never mind.
Okay.
I was worried actual price was in there and we didn't define it. And it was just in the question.
Never mind.
Disregard me.
Actual price is in there, isn't it? Under
Just a method to ascertain the actual price.
right.
So why?
You could say the standard price as opposed to the actual price.
Yeah,
The
I was gonna say,
non-sale price.
because it doesn't sound like there really is an actual price. No one's got anything that they're gonna be able to.
Well,
do
but
that.
there's certainly a non-sale price. Again, if the ad is to say, if you come in this period of time, I'm going to give it to you at a discounted price. Okay, well, what is your non-discount? What is your standard price? What is the typical price, the non-discounted price?
I feel like that, for that reason, actual should actually say standard, because we aren't really defining what actual price is.
Right.
And again, yes, that standard price could be, it could be any number of different prices set by that practice, but it's their standard price versus their sale price.
If you guys are okay with it, then I think standard is easier, since we're not defining what actual is, like if it's MSRP or exact what it is.
Yep.
The next question is continuing the discussion that was brought last time was, how should national companies be held accountable for advertisements that violate the proposed regulations? So we're looking at the last section of the text. I think there were the concerns, with large companies.
Excuse me, Maria?
Yeah.
Subdivision F has a sentence that needs an end to it. And I don't think you move to the next until we've figured out how we're ending that sentence. The licensee shall retain the data required in subsection E for 1 year after the sale.
But the advertisement is published or disseminated.
Ah, okay, because I'm not seeing it on the version that's on the website. Okay, from when the advertisement is disseminated. Okay. Thank you.
Yeah, we'll take a look at the, I'll have to take a look at see what's online, but it should have say that following that statement.
I'm sorry to interrupt. Go ahead. Next question. National advertisements.
Where is that located?
It's on the end of page 4, and it continues on page 5 of the text.
How should they be held accountable? Is it like hot coals or branding irons, or what? Or should we list the various torture devices?
For some reason, when they combine that.
As I recall, our biggest issue on this, the sticking point was holding the dispenser or dispensing audiologist accountable for the advertising of the national company.
And I don't have a problem with that, because I don't see how else you can enforce it. And having been through that myself, it's a matter of me contacting my company that's trying to run the ad and saying, you can't do that, and you can't put me in there because it's against my rules and regulations, and having to deal with it that way. I don't know how else we could prevent national companies from doing whatever they want.
Can't we just fine the national companies?
Can we do that?
No.
No?
Why not?
It's outside of our jurisdiction. Apologies.
Well, I think we
Definitely
should
only
fix
have the
that.
regulatory authority over.
Federal government hasn't given us that authority.
Yeah. That interstate commerce. Right?
So then we find the hearing aid dispenser for something that the national company did.
Yes, if a sale is, if there's a sale from that ad.
Should we give them a warning?
I think it frequently, right, the results of such things are frequently warnings, not necessarily immediate fines, et cetera, right?
Yes, we don't just outright fine someone. We're gonna, try to work with those individuals, especially in the case of national advertisements, and let them know to contact the corporation, let them know they may be in violation of state laws, and most times that works out. But ultimately, it is the licensee responsible for the advertisements. things that are related to their own practice.
So you might also see, in G2.
But it's not their practice.
It does talk about.
Practice of hearing aid, sorry, the practice of hearing aid dispensing, not practice in the, I'm not talking in the sense of a business, I'm talking about they're practicing of hearing aid dispensing, utilizing the license. Sorry, go ahead.
No worries. So G2 is subject to discipline or enforcement action, implying that the administrative action of an educational letter from the board is also an option. So it's more than just discipline. You have all the administrative options as well.
So then there's not really a question there then.
It seemed unresolved last time, so we just thought we would make sure we hammer it out.
Okay.
And then, Maria, you had 5 about educational materials. And I did want to ask our legal counsel, Michael Knotes, to talk a little more, or Karen Halbo, about like right now these regulations remove some of the very detailed but useful examples. But I don't want to accidentally talk about educational materials or creating them when they could potentially become underground regulations. And so I just thought I might have you guys talk to us about that. Either Michael or Karen.
Well, the educational materials, what you had here was specific. What sort of materials are you thinking about being able to send out? Showing examples that if it's a doctor of English, that they can't use doctor. I mean, that's just basically restating what the regulation says. And doing that is fine. It's that if you go beyond that and you're sending it out as instructions, then it becomes an underground regulation. So your educational material needs to kind of stick to the 4 corners of what you have in the regulation and not go beyond that. Sort of a theoretical discussion here.
Yeah, I think at the last meeting, there was some discussion that some of the struck through language were extremely useful examples, and that the thought was, oh, maybe we could make them into educational materials. And then I just wanted to make sure we didn't oopsie and in using what was formerly in the reg as education materials, the little table, that say correct or incorrect.
Yeah.
I just don't know.
It really is. If it's just repeating basically what's in the regulation and giving an example, you're just explaining the regulation. You're not adding new requirements.
In the attachments, I included also a copy of what we have published on the website. And so that also includes like the tables in there.
Right, but I see where Karen's coming from. It includes it because that's what's in regulation right now. So, Sharice, are you asking the committee if we want to go back to formatting these regulations in that educational format? Or are you just saying, can we come up with a educational resource that is a kind of this, not that type of format?
It was kind of both, and because sometimes in a regulation, you'll say, for example, and you provide an example so that it's not so theoretical. And so we will have gone from extremely concrete, easy to see and understand examples to just the language. And I didn't know how far we could go in providing the examples without accidentally walking into underground reg territory, because what they have right now is it's pretty clear and people use it often. I hesitate for a second when I heard, oh, but these are really useful and I use them all the time, should you then truly strike them from the regulation, or should you find a way to say, for example, you know, in the regular, I just made my spidey sense go up that maybe we were losing something by striking through all of them, items that might be useful to licensees or the board when we're explaining it.
I actually had a question about that. Were we striking it because it's something that we, from a legality standpoint, we can't do? Or, I wasn't really sure why that was being stricken, if there was some regulatory or legal reason why we could not have that.
I think at the time, the board and board council made the determination that this probably wasn't the best way to write regulations with, even though it is educational and helpful, it would require a lot of maintenance of kind of this, not that charts. And that probably would be more suitable for educational type material that we could, base on the regulations and stay within the four corners of our regs as much as possible.
I mean, because already it's out of date anyway. It's been out of date for years because it says Jane Doe MA in audiology, and it doesn't address AUD. So, yeah. Something
It
that would have
almost
to
seems
be-
like the type of items that would belong on a website under like the common, like a Q&A section where you can post those answers to common questions, and in there maybe have some of these examples provided.
Or does that become an underground regulation?
Well, I think we'll just have to.
The example shows what the regulation already states. You're not imposing a new requirement. You're not imposing a different rule.
Okay. Because, I think the directions are pretty clear as it's written. In all honesty, but it would be nice to have examples that reflect that on the website so people could see, it's a little bit easier to grasp, oh, okay, that's what you mean by that.
So I think what we will do is we can move forward with these regulations the way they're listed, kind of in, they're pretty specific. And then we can work on educational materials with our public affairs people, and, if the need arises, come up with something that stays out of underground regulations territory and sticks with the education. Is that all we have, right? Okay, I think that concludes our discussion for hearing, dispensing, advertising, unless we have other questions.
Well, it depends on if the committee wants to. Oh, no.
You need to make changes to it.
We have additional changes to bring back, so you could go ahead and go to public comment or any more board discussion in general on it, and then to public comment. Since we need to come back with cleaned up language, right?
We can, the suggested changes was to number 4, D4. So the board, if the committee is comfortable with just that, delegating just to, with as amended, we could bring it next time to the board meeting, or if you prefer that we bring a clean text to the committee, we can do that as well.
I think you also have to change the actual price in E. Should be E1. It should be standard. That's the only reason I thought we were doing some more cleanup, but if it's one of the 2 items.
So what is the desire of the committee?
How many items are we changing?
Just 2 items. 2 items.
Okay.
If the committee wants to make a motion, I think we can go over those changes.
Well, does anyone have any further discussion? Would they like to see the changes again before voting on it? Or I'm comfortable voting on it as it is and taking public comment, but how does everyone else feel?
I'm comfortable voting on it as it is too.
Agreed.
Okay.
Okay, then if we could open it up for public comment, please. On all the things we have discussed.
This is the moderator. The Q&A panel is open. If you'd like to comment on the discussion items, please click on that Q&A icon on your screen, type comment into the text box, and submit that to the panelists. If you have dialed into the meeting, you can dial *3 on your phone to raise your hand. Not seeing any requests for comment directly regarding the text, other than Marty and Bob would like to say thank you for this interesting and informative session. And with that, I will close the panel.
Thank you. Okay, so we're going to need a motion for accepting the changes as stated.
So moved.
Staff, this is Michael. Should the committee be making a motion to recommend this proposal as amended to the full board? Is that what you're looking for here?
I'm looking for whatever language you tell me to say.
Yes, I think that's the case, Michael.
Would you like me to take a stab at it and then, Marcia, you can say that motion?
Okay.
Go for it.
So, move to approve the regulation, amending section 1399.127 as amended in the committee with changes to section D4 and E1. Do you so move, Dr. Raggio?
Yeah, so move, but we're not moving this to
We're recommending it to the full board.
okay, then so move.
Do you have a second?
Second. Did you get my second?
Michael, we don't need to go back out for public comment, do we?
You do need to have committee members, any further committee member discussion, and you'll need to have public comment specifically on the motion, yes.
Okay.
So any further comments from the committee? Seeing none, if we could open up the or comment to the public on the motion.
This is the moderator. That Q&A panel is open. If you'd like to submit a request for comment. And as a reminder, our call-in users can dial *3 to raise your hand. Not seeing any comments, I will close the panel.
If you're ready, Mr. Borges, I'll go ahead and call the roll.
Please.
Mr. Borges.
Aye.
Dr. Raggio.
Aye.
Ms. Chang.
Aye.
Dr. Valdez.
Aye.
Dr. White.
Aye.
Motion carried.
Huzzah. And I believe that's the last thing we have on our agenda. So I Move to close the hearing aid dispensers committee.
Since it's almost 4:15, I would propose that we close this meeting for today and pick up in the morning.
Okay.
Adjourned at 4:11.
Thank you all. Talk to you tomorrow.
Thank you. It starts at noon again tomorrow, right?
9 a.m.
Go.
Funny guy. Thank you, everyone.